So with that, we're now going to go into our next session, and it's a really interesting one. Well, they've all been really interesting, haven't they? It's been fantastic. But we're going to hear from Mary Dixon-Woods, who, of course, is the director of this institute, about developing large-scale collaborative multi-centre research for improvement. And what we're going to be focusing on is examples that showcase how to do the doing. And do please put your questions in the chat, because we're going to have a panel discussion after a series of 3 films. First, of course, is Mary's. Then we're going to have one from Iain Moppett, who's Professor of Anaesthesia and Perioperative Medicine at the University of Nottingham. And then from Aneel Bhangu, who's Honorary Consultant Colorectal Surgeon at the University of Birmingham. So let's start with Mary.
Hi there, I'm Mary Dixon-Woods, and I'm delighted to be talking to you today about designing and testing solutions at scale. And of course, we have a very long history of collaboration-based approaches used as part of improvement, and this has been summarised as part of the This Institute series published by Cambridge University Press. And if you'd like to see the evidence on that, this chapter presents an overview. And collaboration has this long and very important history from which we can derive a sort of definition or a kind of understanding of what it involves, which is that if you use a collaboration-based approach, it involves a network of people who come together to cooperate around a common interest with a shared goal of improving care and mutual learning. I'm going to suggest to you today that trying to do that at scale can offer a lot of advantages and possibly has been an unexploited or underexplored way of doing improvement, in contrast to the currently dominant model of doing things small and then seeking to scale up. Now, what we've been doing at this institute is trying to create the infrastructure for this through an online platform we call Discovery, which seeks to bring people together with answers. And the people with answers are characteristically people with what we call lived expertise, meaning the patients and staff of the NHS who are able to bring their experience, their knowledge, their ingenuity, and their deep insights to bear on helping to both understand problems and design and test the solutions. One of the first and very important things that you can do using collaboration and trying to do it at scale is collaborate to understand the problem to be solved. And this is a really key task, because we know that the way the problem is defined and from whose perspective has very important influence on the selection of solutions. And understanding the problem is something that can be done at scale. And we saw some really great examples of this during the pandemic, when the COVIDSurg collaborative, which you're going to hear a little more about, began to understand some of the issues to do with head and neck surgery as they might be affected during the period of high rates of infection. At scale, collaboration also helped to identify the variations in treatment modifications that were happening, and also characterized that many of those modifications were being driven largely by pragmatism, but also found that there was lack of clarity on which were optimal. So that kind of understanding the problem at scale had a very important role in understanding where improvement efforts might best be targeted. And again, we can see important examples of this when you dig down into what might be causing some of the challenges that we see in improving quality and safety in healthcare, including, for example, this great survey of the mismatch between drugs implicated in events and what anaesthetists thought were causing those events. Particularly important to understand problems from the perspectives of patients and carers, and we're seeing an increasingly important role for qualitative studies and other means of gathering insight from patients and carers. But I think there's a growing urgency about seeking to do that at scale. And it's particularly important as we begin to grapple with issues like the burden of treatment and some of the changes in organisation and delivery of care that might increase the burden of treatment for patients. A second thing we can do at scale is collaborate to build shared visions for what good looks like. And this is really critical once we begin to recognize that there can be two very legitimate ways of looking at the same problem, but it's really important that we understand what those different ways are and begin to reconcile them. So one of the things we've been doing using Discovery at this institute is gathering perspectives from multiple groups who might be important in understanding how to design and deliver services. And that most importantly includes patients. And if we look, for example, at the shift to remote care during the pandemic, this study was able to identify that patients and clinicians agree that remote care is suitable for 5 areas of COPD care, but they don't agree on a further 5. So clinicians think they're suitable, but patients don't, and there's no consensus on the final 4. And that kind of finding then has big implications for how you design services that patients and staff find satisfying. Similarly, we can use collaboration at scale to begin to design quality frameworks that meet the priorities and are suited to the different perspectives that different parties are bringing. So this fantastic work led by Lisa Hinton collaborated at scale to identify what was important to people about the shift to remote antenatal care, and was able to build a very practical quality framework that can help guide policy and practice. A third thing we can do by collaborating at scale is build measures for improvement. And this is an area where there's essentially been a lot of neglect. We do know that data is absolutely vital to improvement, but it's also very, very hard work, and often is a major challenge for teams trying to do improvement. We know that there are all kinds of issues in definitions and how easy it is to collect data against definitions. And one of the most important problems is that we have a huge issue of measure proliferation. So vast numbers of different indicators of quality and safety. In the case of perioperative care, nearly 1,300 different clinical indicators, but a systematic review found that over half have no level of evidence described in the literature. Very few are patient-reported or measured domains that patients themselves would see as important. So collaborating at scale to consensus build and select the small set of items that are likely to be most important to patients is a key task for large-scale collaboration. A further area for large-scale collaboration lies in reducing the problem of priority thickets. And this is a problem that's familiar to anyone who works in the health service, which is that there is no end of recommendations and guidance coming at the service, but very difficult to turn them into solutions, and often very little sense of prioritization that would help guide and clarify goals for services themselves. So too often the response seems to be just grow more hands. But I think one of the things we can do by collaborating at scale is produce that prioritization list and begin to do the very important work of co-designing solutions at scale at the right level in the system. What we do know is that many improvement recommendations which come out of things all the time, like root cause analysis and so on, are poor quality, they're not based in good evidence, and they have not involved patients or staff in design, implementation, or evaluation. And this is really a problem because changing processes, systems, and cultures requires, as you all know, structured methods, skills, and resource. But it's also the case that the change is not always being designed and implemented at the right level. So we have a challenge on the one hand of an awful lot of stuff coming at the system that's handed down top down. And at the other hand, we have an awful lot of small scale improvement activities that are poorly coordinated and can lead to reinvention, waste, and suboptimal solutions because they're done by people who often don't have access to the right level of expertise or indeed influence in the system. So we have a problem of many hands, so many actors in the system seeking to do improvement, but because their efforts defy whole sector coordination and action, they may have the paradoxical effect of undermining system safety, for example, by producing destandardized approaches to clinical care. So we not only have the problem that we are reinventing wheels and potentially producing an awful lot of waste as we do so, but that waste can be very unproductive. And we can see this, for example, in the case of the history of early warning scores, which have a very important role in detecting patients who are deteriorating. The need for those was recognised in the early 2000s, but local systems proliferated, leading to an awful lot of wasted effort but also an awful lot of unwarranted variation. So by 2017, it was recognised that this was causing confusion that can compromise patient safety and that could be eliminated through use of a common tool. So a really important example there of how we need to be designing at scale from the beginning for many areas of improvement. So my suggestion is that we need a lot more coordination and integration of process improvement using co-design principles and building on existing evidence. And to give you an example from the pandemic, it was clear straight away that many established clinical processes would need to be adapted for a COVID scenario. One of these was the situation, the obstetric emergency, where a person is having a postpartum hemorrhage, but that process, everyone knows how to handle that if you work in a maternity unit, but how do you handle it when the person is COVID positive was the question. And we were able to develop a methodology that could co-design that modification very rapidly on discovery. So it started with recruiting a crowd of maternity experts, infection prevention experts, and human factors experts. They were shown a very short video and asked to say what they would do to improve the practice that they saw. They made multiple suggestions, which were recorded on Discovery. This was free text suggestions. And then we were able, over 2 rounds of a Delphi process, to consensus build what they would recommend should be implemented in practice. On the second round, they were presented with the scores that they had themselves given previously, but also showing the scores that others had given. And the end result was 16 recommendations to improve the practice seen in the video. We were then able to reshoot the video and illustrate consensus-built, co-designed good practice. That was very successful. The video has been viewed over 100,000 times on YouTube and endorsed by the major professional bodies, as well as by Martin Bomley, the fantastic patient safety advocate. So that's just one example, but it can show you that you can build processes and systems collaboratively. You can engage diverse and distributed expertise, and you can do that at speed and scale. And you can do that using multiple different groups and many, many different forms of expertise. Clearly important not just to design improvement, but also to evaluate. So design is really hard, but it's actually the easy part of doing improvement. It's an ongoing frustration that it remains too difficult to answer the question, does quality improvement improve quality? And I think by large-scale evaluation, we can do much better at that. If we look, for example, just to return to early warning scores, we currently have 7 different pediatric warning scores across the UK. The diversity has arisen because of multiple locally developed systems, but they differ on the variables they're measuring, the thresholds, the escalation algorithms. This has many patient safety consequences, including complications relating to transfer of patients and risks with different staff training and experience. Now, they also don't necessarily all have the strongest evidence base. And one of the things we can do to try to improve situations like this is commit to evaluation. But it sadly remained the case that evaluation is sometimes seen as a sort of ivory tower discretionary exercise that's of limited relevance to the hard work of getting things done at the sharp end. But I think if we can work at scale, then there really are huge opportunities for multi-centre evaluation of promising interventions where we can aggregate small contributions to large benefit. So I'm really hoping that's the direction that we can move in the future. What that then involves is collaboration at scale to understand the problem to be solved, to build shared visions for what good looks like, to build measures for improvement, reduce priority thickets, co-design solutions at the right level of the system, and evaluate so we can get to better, faster, and more inclusively.
So thank you very much for joining me this afternoon. My name is Iain Moppett and I'm the Director of the Health Services Research Centre at the Royal College of Anaesthetists. And I'm planning to spend the next few minutes talking to you about how we at the HSRC have developed large-scale collaborative multi-centre research for improvement. The outline of what I'm going to talk about is essentially a little bit about what we have done. I'm not expecting most people who are listening to this talk to know what the work of the HSRC does. A little bit about how did we go about that and what did we do. Some reflections that I've got around what made things work, and also some reflections about the challenges that we faced and we face going forwards. Before I start, I'd like to clearly acknowledge that really I'm speaking on behalf of other people. These are some of my colleagues who've really helped deliver the work of the HSRC. And the top left, you've got Sharon Drake, who's the Director of Clinical Quality and Research at the Royal College of Anaesthetists. And we've got Dave Murray, who's the Chair of NELA, the National Emergency Laparoscopy Audit. Ramli Munisinger, who was my predecessor as the Director of the HSRC and is the Chief Investigator for PQIP, which I'm going to talk about. Tim Cook down the bottom right, who's the Director of the National Audit Projects, and Sarah Hare, who is both my Deputy as Deputy Director of the HSRC and was also previously the Clinical Lead for NELA. So what do we do at the HSRC that's relevant to this talk today? Well, we actually do a lot of stuff, but I've just picked out 3 of the projects that we've been running for some time. On the top left, you can see the Perioperative Quality Improvement Programme, which has been run, which is led by Ramli Munisinger as a collaboration between the Royal College of Anaesthetists and University College London, who are the sponsor of this research study. And that's very much an elective surgical programme looking at quality improvement in major elective surgery. In contrast to that, the NAP programme, the National Audit Projects, have been going on for a while, and these are essentially, although they're a suite of projects, they are standalone projects which are looking at rare events. These are events which are too rare to be studied by in clinical trials, but common enough to be able to study them, and they're defined by events or occurrences which are clinically important to patients and to clinicians. And by the nature of the rarity of those events, they require a whole nation approach to actually collecting these data over approximately a year. And then again, same but different. And we've got the NELA or NELA, depending on where you're from, the National Emergency Laparoscopy Audit, which is a program which is commissioned by HQIP. So this is a nationally commissioned program which is looking at emergency laparoscopy patients. It's very much a multi-professional, multi-specialty registry, which is ongoing, collecting data on these patients across England and Wales. And so those are the projects which I'm going to talk about and which we're very proud of. And when I was thinking about this talk, I was thinking what's notable about these projects. And I think the things which link these projects are their longevity, their reach, how well they reach out into our community, and some of the impacts that these projects have had in different ways. So what do I mean by that? What do I mean by longevity? Well, the NAPs have been going for over 15 years. So in the college, they've been sequential NAPs. Where actually, I showed you a picture of NAP 6. We're in the throes of finishing off NAP 7. So these are projects which have been going on for a long time. NELA has been going for over 10 years. PQIP has been going on for 6 years. So as a college level, we've invested in these projects. They're not just let's just do this, flash in a pan, and off we go. Projects which we're very much invested in and are carrying on. When I talk about reach, what I was really thinking about was the fact that we really get out there into our community, into our clinical community. So a quick totting up across the projects is probably over 100,000 or more detailed patient episodes across those projects over the time they've been going. So there's a lot of patients with very detailed individual patient level data. And one of the key strengths that we have, and this is the key strength really, it's a key strength of the UK system and the National Health Service system, is that we have reach into all NHS hospitals. So we have a whole system reach for the projects that we're doing. We're not confined to one small organisation providing bits of care or a bias sample. We cover the whole of the NHS, whether it's big hospitals, small hospitals, rural, teaching, and so forth. And in terms of our clinical reach, we've got a local lead for each of these projects. It's often not the same person, but a local lead at every site. So every site is engaged with these projects. And then in terms of impact, what have we achieved? Well, in their different ways, the different projects they've achieved individual change. If you go and ask anaesthetists, they'll tell you that in different ways, they've individually changed their practice on the basis of the findings of the projects. They're resulting in local change. So local organisations have changed their systems, changed the way they work. They've introduced, for instance, following on from the NAPs, they've introduced airway leads into their local trust. They've changed the way they do their equipment. And they've introduced system change. P-Equip has had an impact on things like the national commissioning, so things like sequins. NELA clearly through its registries and through best practice tariff has influenced the way we structure and fund healthcare throughout. So they've had an individual impact, local impact, and impact with system change. How do we do it? I found this a really hard question to answer. It's easy enough to ask, but what are the strands that I wanted to bring out about what happens? Well, I think leadership is really, really important. I've given you some concepts of who the leaders are, and those we're very fortunate. We've got clinical leaders. Each of those people, like Sharon at the college, are clinical leaders. So these are people actually out in the community. This isn't research or projects or improvement plans being done to others. These are projects which we are all invested in. So we've got strong leadership, and a link to that is very strong leadership from the college. We are extremely well supported by the Royal College of Anaesthetists, and Sharon in particular has been there a long time, very senior leader, very supportive. Giving us that structural support to allow us to get out and do these projects, which, although they are by and large delivered by the community, by our clinical community, very much without that structural support, which comes from Sharon's leadership, leading on to having excellent support within the college, from administration and IT, and all those other factors to mould things together. So we've got those structures. We've got that leadership, and then we've got a tension, I guess, between designed projects and the evolution of projects. And all of these projects, to an extent, were designed. Some more designed than others. So, for instance, P-Equip was very much there's a protocol. It's a research study. There's a protocol defining what it's going to be. NAPs very much evolved from initial ideas, developing a method, and then taking that method forward. But they've all got an element of design to them, but we haven't been afraid to evolve those designs. When something hasn't worked, it's changed. When there's been a new priority, we've changed it. A really good example of just adapting to the environment is the way we, I say we, it's my colleagues, in the NAP project with COVID, that put the NAP project on hold, and the current NAP 7 project on hold. But they just repurpose that tool and those networks that we have to be able to look essentially at the impact of COVID on the way we're delivering care. So that adaptability, that tension between design and evolution. What else do we do? Well, I guess I've hinted at this quite heavily already. We are very fortunate. We have got local networks. We've got leads for all of these projects in essentially every NHS hospital in the country. So providing that grounded sense. This isn't a big research team in the college doing things that other people are doing, or the phone calls for them, or anything like that. This is local leadership really being engaged with what the projects are about. No one these are all voluntary jobs. Nobody's made to do them. No one's paid to do them. So we've got that sort of local, the local networks and that engagement. And then finally, in terms of what makes these things work, I think it's the relevance of what we're doing to the day-to-day. These aren't esoteric projects. These are projects which impact either on individuals' clinical practice. So you take the NAPS, we've looked at sort of the core of anaesthesia, which things to do with like airway management, anaphylaxis, perioperative cardiac arrest. Those are what's going on at the moment. PQIP that's all about how do we improve outcomes for the elective patients, and so important to clinicians now with the elective backlog. So these are things which we think are relevant to the day-to-day practice of the clinicians on the ground. But behind that, I think actually there's also a bit of a hidden agenda. And I guess I'm going to lean perhaps a little bit on what Mary Dixon-Woods talks about in some of her work. The stuff that we don't realise that's why it works. There is a degree of peer pressure. If every trust in the country is taking part in a project, well, maybe we should take part. So there's that little bit of edge. And interestingly, I think there's a degree of collective pride within the anaesthesia community about our ability to do these large-scale projects, and that pride is well placed. We've done these well. When we had discussions about the future of NAPS, one of the things that came back is, look, we do this really well. These are nationally recognised, they're internationally recognised, and that sense of pride and that sense of belonging, that sense of community amongst the anaesthetists, saying, we do this really well. We will provide, we will input into this collective effort, I think really helps. And then people might not talk about this, but the reality is that whether you're a trainee, whether you're a consultant, we all have appraisals, we have ARCPs and jobs to get, and actually taking part in these collaborative projects, it goes on somebody's CV somewhere, and I think it would be verging on dishonest not to recognise the fact that people do things and take the there is an element of reward by taking part, and we make significant efforts to recognise the involvement and contribution of everybody to the projects that they get involved with. So I think there is a bit of a hidden agenda to what we do. So what do we do well? Perhaps to labour the point, I think we do well at engaging our community, getting them involved in the research, having projects which are relevant to them, and feeding back to them and recognising their contribution. I think we're pretty good at being visible within our community, within our clinical community. If you ask anaesthetists, they know about the emergency laparotomy audit, they know about PQIP, they know about the national audit projects. So we're quite visible. And linked with that, we can demonstrate that we've had changes in practice. Those things I talked about, where individuals say, I changed my practice because hospitals where departments have said, we changed our practice on the basis of a recommendation or some finding. And those larger national changes where we're driving national change, driving that national discussion. So I think those are some of the things that we do well from these large scale projects. What do we do not so well? Well, I suspect this may be a common theme. I think agility is an issue. The projects take a long time to set up, to bear fruit, and I think we can be as guilty as others are of just taking too long and not having that responsiveness to what's going on. Conversely, as I said, the NAP projects, when they couldn't do anything, they were extremely responsive. They got data out within weeks from some of the COVID work they did. There is definitely that element of fatigue, and we've experienced that people are collecting data on the ground, perhaps feeling not another project to do, I've got enough to do. Dissemination, I think I challenge any project to say that they did dissemination brilliantly, and there's always work for us to do to work out how do we reach people, how do we reach the communities that matter, how do we reach the decision makers that matter. And then lastly, evaluation. We're very good at getting the data in, not so good at getting back, saying, did it actually, what difference did it make? Should we look at this again, having done this, we've made these changes, what happened, has anything actually improved? Do we just feel good about it, or have we made a real difference? So those are some of the challenges I think that we face. So hopefully, over the last quarter of an hour or so, I've given you a flavour of some of the large-scale collaborative work that we do with the HSRC. I've talked through what we've done, a bit of what we did, what made it work, and maybe left you with some thoughts and some questions about the challenges that we face. Thank you very much.
Hello, it's a real pleasure to be talking to you today. My name's Aneel Bhangu. I'm a consultant surgeon and I'm a senior lecturer in surgery at the University of Birmingham. I'm here to talk to you about our research experience and how we build networks to deliver fast data that leads into trials that then we're pushing into policy change. This is where we are, the University of Birmingham, and so it's what we call an integrated campus. I work in the hospital, which is the 3 white blobs at the bottom. My office is across the bridge, which is in the university, and we can reach down in the campus. And this means we've got a really solid footing to deliver very fast studies. And we started doing this and building networks by linking trainees across the United Kingdom. And what we realized once we started doing this and publicizing it by doing small studies, small audits, is that people around the world also wanted to join these networks, especially surgeons, because we're a community. And so we started designing studies that could be delivered across the world. And what I'm going to talk to you about today are some examples of those studies, but also the lessons we've learned. One of the key lessons we've learned is our authorship model. So we publish under one single corporate name, which you can see here. And that takes a lot of the heat out of the situation of whose name goes first and who are these top 10 authors. And we list everyone at the end. So everyone appears on PubMed as collaborators. We work with the journals to make this happen. We've removed papers from journals in the past where they've refused to, or they just practically can't execute this authorship model. And so we know which journals will go with it. And it's really nice to talk to the journals and the editors and explain our authorship model and help them arrive at this level of change too. We actually won a Guinness World Record last year for the most collaborators on one of our COVIDSurg papers, which was 15,000 people. And that's the most collaborators of any scientific paper ever. So everyone contributes a little bit, but without each other, you don't get the whole. And so these people do qualify for collaborator status and authorship, and we're very comfortable with that, and it works for us. So once we'd started these light touch studies, we applied to the NIHR to become a global surgery unit. This was competitive. We've been refunded, so that's a total of £14 million to deliver research across 7 hubs in low middle income countries. That's Mexico, Nigeria, Ghana, Benin, Rwanda, South Africa, and India. And but we span the world. We've got 140 countries in our network, over 3,000 hospitals now, and we've included 500,000 patients worth of data into our databases. And I describe this as the Amazon of the surgical network, because if you want a study doing tomorrow, we'll sort of do it. And we met face-to-face recently in India, which is the first time in a few years, which was very nice. And those face-to-face meetings remain very important for our network and prioritizing it. So one of our USPs is our ability to deliver large trials. So Falcon looked at wound infection and different types of stitches and skin antiseptic solutions. That recruited nearly 6,000 patients and was published in The Lancet. Cheetah has just completed, so that's 12,800 patients. Bearing in mind, surgery is coming from a place where a big randomized trial was 100 patients. We're now into really large trials that delivered during the COVID pandemic. So that's from 7 countries, and that showed that discussed a change of instrument and gloves before closing an abdominal wound to reduce infections. That will be published on October the 31st in The Lancet. At risk of revealing the results, that showed a very robustly positive effect. And that means we will now look to change global practice for the millions of operations done in the tens of thousands of operating theatres around the world. And we'll be looking to change global practice. Penguin is a collaboration with the anaesthetists, and that's recruiting 10,000 patients. And these measures are all recommended by the World Health Organization, but they're backed by very moderate evidence. So we're trying to improve the evidence base for things that are everyday and common to a range of surgeons. We have a range of other trials launching. We've changed the paradigm in surgery from doing trials, stop, 2 years to write results, try and restart another study. We're now overlapping our study, and we're trying to publish Falcon was accepted into the journal within 60 days of the last patient being entered into the study. So we're trying to be really proactive in our data cleansing and missing data approaches. And this is the Falcon study that was, if you sort of scan that code, you'll get to the paper that was published in the Lancet. The other thing we've learned is that publishing the paper is not the end. This is just the beginning, because we now have to push all of this into policy change and clinical practice. And if anything, that's the harder challenge to do. So we have a research cycle, which is prioritization by frontline surgeons, delivery of observational data to power these studies, followed by some form of interventional study to prove whether these interventions work, followed by policy change. And once we connect up that cycle, that's our logic model, that's our theory of change model, that's how we will lead to faster change, not in 10 years, but in 2 years. And then COVID came along, and our network asked us, what do we do? Do we keep operating on patients? So we launched a really rapid observational cohort study, and I'll talk about what worked and what didn't work in a moment around that. And that was published in the Lancet in May 2020. And then we published another paper subsequently in Lancet Oncology looking at the effects of lockdown on cancer surgery. So these are great, but it's a really humble celebration, muted, because the mortality from these 1,000 patients who underwent surgery at the beginning of the pandemic, who had COVID, was 25%. That is the highest mortality of any series of patients ever published. And I do remind people that includes young women undergoing minor surgery who really should traditionally have a mortality rate of 0. So this led to the global shutdown of surgery, and it saved thousands of lives. And part of our job now is to restart surgery. We have also had a paper accepted on what to restart surgery. We developed a resilience index. So what is a resilient surgical service? And we developed this index. We validated it across thousands of operating theatres in the world, across all specialties. So this paper and the Cheetah trial that I spoke about are going to be released in the Lancet on October the 31st at midnight. And why then? Because we're actually with the World Health Organization in Colombia on that date. And that's part of our efforts to link this research into very rapid policy change. And how can we scale these studies around the world to reach not just research active surgeons, but everyone. And that's how we're looking to close this cycle of research into policy change. But it's a real honor to have 2 research papers in the full Lancet at one stage. But as that is a platform to take the next step into broader policy change. So one of the questions for this talk is how we deliver these observational cohort studies, and how do we manage to achieve such rapid networks? And so I'll talk a bit about the COVIDSurg study, which responded to need. I don't set the questions, I respond to the questions. We add the methodology in the teams. So our mission from the COVIDSurg study very quickly was to provide very quick, high quality data during the start of the pandemic. There were a lot of guidelines coming out that were just based on opinion, and we recognized we needed to present data. So we established a network, and the real effort was in sustaining that network, because there's a lot of excitement at the start, but you have to see it through to the end. And how did we do that? We established a network predominantly. Social media was our first step. There you find the research active, communicative collaborators. We then established a central team who were locally in Birmingham. These are the PhD fellows and the postdocs and the statisticians who every day during the pandemic delivered this study. From the social media groups, we identified national leads, and they developed their own WhatsApp groups, and they pushed the studies across their country. What we did at the start, and this is my recommendation, is you establish the identity of one project, and you focus on doing one project really well and really quickly at the start. I've seen people launch multiple projects, and they're very hard to publish multiple projects. Publishing one project is hard enough in a short time frame. And definitely have somewhere to go so people can have a web page with their email sign up. Keep all of this tech as light as possible. It's Twitter, it's WhatsApp, it's basic web pages. And then you need to build teams around these things. And that's what I call sustaining a network. So we had weekly meetings with us and with our national leads, And my advice is not to cancel those meetings. It's really easy to get busy, but we meet on a Thursday at 9 o'clock, and no matter what happens, there are people there. If I can't make it, the meeting still takes place without me. And so everyone's got a grounding place to deliver these studies. Weekly emails and communications, and not everyone reads them, but they know they're coming. I think it's important to make rules at the start and not to break promises. And a lot of this is around the authorship. So we make rules. We're flexible with the number of people in a team, for example. But if we say we're going to list everyone on PubMed, you must list everyone on PubMed. If you don't list the people because you try and acquiesce to the journal, then your collaborators will never come back to you. Don't overpromise. We don't promise people we're going to publish in the Lancet because we don't know. We don't promise people we're going to publish within 60 days. We say that we're ambitious and we will try and submit this stuff as quickly as possible, but don't overpromise. We really try and support our national and regional leads because they're the ones who deliver the hundreds of hospitals each into these studies, and we're generous with them if they've really performed. We invite them into writing groups, even if they're not experienced writers. And then what we do is we have the corporate authorship, and then at the end of the paper, we list the writing group, the analysis group, the protocol group, the collaborators. I don't promise authorship at the start. That is a mistake because the people you start with, some of them have to leave very quickly, some of them don't do anything. So actually you need to sort out your writing group at the end. However, you do need to include those people who were with you at the start and did the first few months of hard work and helped you set up. So have an inclusive writing group. It can be relatively big. Our writing groups are typically about 30 people. And try and set that completely at the end. And try and deliver an early output. I think people get very frustrated when it's 2 years down the line and nothing's happened. So clean your data and chase missing data as you go. And this applies to our randomized trials as well. We have hard database and authorship locks. We always get this tail end of people saying, give us another week, give us another week. My experience has been that those people never deliver into your study because if they haven't managed to deliver during your period of time, an extra week isn't going to help them. Focus on one clear early output and keep that relatively simple. Don't overcomplicate it. But actually driving that last 5%, in my experience, is the hardest. Getting the paper finished, getting the analysis done, getting it submitted. Then you get hundreds of reviews from the peer reviewers. We've all been there. But that last 5% is the hardest. And that's when you still need the team. You still need the weekly meeting. You still need to aim on that one output to get published. And I've spoken about this. This was our first paper that published in the Lancet from COVIDSurg and showed a very high mortality. And that was even in elective minor patients and emergency minor surgery in women. But actually, over the course of that project, we unpicked every stage of the pathway and published and we were lucky enough to publish in multiple journals because we pushed the data out fast. And we know these had a very high impact on patients and delivery. We've monitored all that, it's been an honor to be part of this. And I think it did legitimately save a lot of lives. And it was covered in the mainstream media around the world, which again tells us that these topics are important to the general public. We build patients in at every single stage of what we do. And we actually generated patient information during that stage of the pandemic that was downloaded 24,000 times. And that's our patient leaflet you can see there. So very briefly on the future, we're constantly scoping and our network, these are just the individual surgeon messages. And this is how we send out trend surveys every year. So we pick up the new trends that are coming and we plan our cohort studies from these. So the two next studies we're going to launch in a similar vein. One is around environmentally sustainable surgery. That's probably interesting to a lot of people listening. So the governments have committed to net zero healthcare. But operating theatres contribute at least 25% of the hospital's carbon output. So you can't achieve net zero healthcare without dealing with the operating theatre. Also, the operating theatre is a really good place to start. If you try and change a whole hospital at once, you probably will fail. It's too complex. But an operating theatre has 4 walls. It's a complex environment within there. You've got 4 walls and 1 patient. So you can build research around that. And that's exactly what we're aiming to do. And we've also launched a study on inguinal hernias. The study's not really on inguinal hernias, but we're going to look at the global backlog in waiting lists. We're going to look at the environmental sustainable practices that are being delivered. And so really this is an outflow in elective surgery. my 3 take-home messages are to build flat, empowered teams. It doesn't matter who's in control. Give away credit. Don't have lead authors. Focus on setting the question. Broad questions for us are really important. We try and identify questions that are important to taxpayers and make sure you can deliver on that final 5% when everyone's tired. And aim for early outputs. I think early outputs are build your brand, and they change the way people view your network, and people will always come back. So it's been a pleasure to talk to you today. I'm around to answer some questions, and I hope that's useful as you look to deliver your own studies in the future. Thank you for listening.
Aneel, that was an absolute masterclass there. So much information. Iain, also so many insightful recommendations. And Mary, also a fantastically useful set of presentations. But can I bring 2 more people into our discussion? Ruth Glassborow, who's Director of Improvement at Healthcare Improvement Scotland, and also Susanna Stanford, who's a healthcare safety advocate, particularly I think in obstetric anaesthesia. And well, there's so many questions, and Mary and I kind of going to do a bit of a double act here, although I just say I feel a distinctly second-rate partner in this. But first of all, Mary, what happens when things go wrong, and what sort of things go wrong? I mean, we had from Aneel there a great long list of things that would make it possible for it not to go wrong. But what do you do with the kind of people that say it'll never work in Bury, or it'll never work in, whatever other town? How do you deal with that?
I think there are many, many, many things that can go wrong when you're trying to do collaborations, particularly these extremely complex and often quite sensitive collaborations. And Aneel and Iain have both talked, I think, mostly about collaborating with clinical colleagues and mostly in a single discipline. I'd be particularly interested when it comes around for their views on the extra risks once you start including patients and you go beyond a single discipline. But even with those boundaries, it's still pretty touchy. And I don't think there are any answers. I think I have to say I've just been massively inspired by those 2 presentations. I think this sense of, with some will, some infrastructure, you can mobilize these massive groups of people, and in Aneel's case, all around the world, and just do a huge amount of good by essentially asking everybody to contribute a little bit. It's fantastic. And I think what you and your teams have done is really inspiring. So I think it's a model for the future, and building in the safeguards is going to be a key goal here. And I think we're already beginning to get learning from your successes, but I'd also be really keen to hear about what needs to be done to make sure this kind of works.
And Aneel, COVID was a huge motivator. I mean, everybody had to come together. But how are you going to keep the momentum going when there are other conditions which are not so very pressing and urgent?
Good question. And lovely to see everyone today. I think I had a moustache when we recorded the video, so I haven't.
You had a magnificent moustache. Let's not call it a moustache, Aneel. It was a magnificent thing.
Well, because I travelled to India for our global surgery meeting, and then I was in Colombia with the World Health Organization, so I thought it might help me with immigration. But then there comes a stage where you have to sort of do some male grooming on these things, and I've got 2 young kids. I just didn't have the time. Look, to answer your question, the COVID piece, and just to go back to what Mary said, that was the first time we've cut across specialties. So we had representation from all the surgical specialties, anaesthetists, we had non-doctors, non-medical people taking part. And that was quite a threshold for us to cross, actually. All the same principles held tight around authorship, around, we don't collect nice data. We only collect necessary data. So if it's really nice to have, we do not collect it. It has to be necessary. 1-page CRFs and stuff like that. And you saw that in the recovery trials as well. So we know it works. To the second part, how do we keep going? Well, people now ask me, what do I do? What are my research interests? And I've always struggled to answer that. So what I tell them now, and this is really an outflow from what's happened to us over the last few years, is that I only do topics that are of interest to the general public. So I no longer do sort of left toenails. If it's cross-cutting interest to the general public, if it doesn't pass the mother test, as in, does your mother understand it and does she care about it, then I don't do it. And I'm a bit flippant in how I say all that, but what it really focuses on, what I'm trying to say is we spend a lot of time focusing on our question. We spend more time focusing on our question than the execution. So we make sure it's relevant to people. We make sure people understand why we're asking that, and we make sure people have time to feed back to us. And by doing that, so we've got one theme on sort of green surgery, we've got another theme on inguinal hernias, which are a type of operation we do for lumps and bumps on the tummy wall, but it's got nothing to do with the operation. What we're really looking at is global backlogs for surgery and things like that, and those are things that are of interest to the general public. Are people going to have to wait for their operations? So that's my answer. Prioritization is everything before you set off, and I think people need to spend plenty of time doing that, and then short, sharp execution.
Susanna, how does this resonate with you?
Well, actually, I've done, I spent 6 years on the steering group for the UCOS, which is the UK Obstetric Surveillance System. And actually, what Aneel's just been said really resonates, because on that steering group, we used to spend so much time whistling down the necessary data points. And if it wasn't going to be relevant for the final paper, do not collect it. Researchers always want to collect every bit of information they possibly can, and you have to be really mindful of the time commitment that you are asking of people, particularly when they are already really busy. So that would be my main comment in terms of the relevance to clinicians and actually getting the data.
And if you talk to Martin Landry, who of course initiated the recovery trial, one of the things that was really successful about that was that it was a one-page form, that it didn't require people to do a huge amount of work when they were already pressed. Ruth, what are your thoughts on this?
Yeah, so just to explain in terms of the programmes in Scotland, we run programmes across the whole of the health and care system. So it's acute, mental health, primary care, communities. And the data is such a challenge, particularly once you move outside the acute system and finding the meaningful measures. And one of our big challenges is around getting comparative data across the system when we're doing the large scale programs. So we often find that even when the data is already collected nationally, that one of the issues is that the operational definition at a local service level will be very different, and hence trying to get that comparative data to meaningfully get lessons out of is really challenging. But right now, in the context we work in, the other big issue for us around the data side is people's capacity to engage. It's always been challenging. It's even more so at this stage in the work we do. And particularly on the qualitative side around interviewing and getting the qualitative input, that can be very challenging when you're doing improvement in highly pressurised service contexts.
And that goes back to your point, Mary, about reinventing the wheel, because and what Iain was saying about getting stuff out there and dissemination, because if you're to avoid reinventing the wheel, that getting the information out there in a timely way is so important.
I think that's absolutely right. And I think what I found so impressive about this is that really we should be designing solutions once and designing them really well and co-designing them with the right people and answering, as Aneel says, the questions people want answered, and doing that as Iain has described with rigor. And I think if we can design things once and evaluate them once, then it's much easier to do the local adaptation. But this model of having everybody coming up with their own solution is not sustainable any longer. And I'd be really interested actually in Susanna's view on how patients can get involved in these kinds of answering the questions, particularly if they want to do what we were talking about this morning, give voice and be included on their own terms. And that may involve going beyond some of the data that's currently being collected to allow more qualitative forms to come into.
Yeah, I think the really key point when you're trying to talk about public and patient involvement is that you want it early on and then throughout a process. You know, if you bring in the patients at the end of the whole thing, then you're not going to get meaningful contributions from them. And yet, if you involve them early on, you actually can get them to help shape what are the key questions. I was really impressed by Aneel kind of saying, well, you know, we're doing the questions which matter, you know, which anybody will understand. And it's, you know, actually, yes, but also sometimes experts will have a particular view of what they think matters, but often patients have a slightly different perspective on what matters to them. You will really see that particularly with long-term health conditions and mental health conditions, I think. So yes, my answer would be get the patients involved, but get them involved early and consistently. Lisa was talking about the ABC project this morning. Well, actually at our full pace, we were meeting, our PPI group was meeting every fortnight for 5 months. And now that took a really significant level of effort from the ABC team. And I really would like to acknowledge that, because it wasn't mammoth effort on their part, but it really did mean that we were listened to. And I actually think that it has made the outcome better. And I think that's speaking for everybody involved.
Now, Mary, that was underlined about your work with COPD patients, where you had really quite different outcomes in remote monitoring needed by patients rather than by the professionals. But I've got a question here from the audience, which is I want to address to Iain. What's the best method of collating results from several geographical areas? Because you cover the whole country, didn't you, Iain?
Yeah, we do. All our projects cover essentially, effectively, the 4 nations. The biggest barrier is, particularly when it goes into the research world or gathering data, is the fact that, and lots of people on the call will know this, is that the structures for collecting data or for getting approvals across the 4 nations are different. I'm not going to say who's best, but they're definitely different, and that is a structural barrier to getting stuff done at 4 nations level. And I certainly know of projects where people have given up on one of the 4 nations because they can't get through. Having said that, because the world I'm coming from, as you say, sort of a single specialty in terms of anaesthesia and perioperative medicine, our colleges, our associations are 4 nations, so we don't see those barriers. Again, I guess in my world, I suspect it's the same issue for Aneel, that the vast majority of people work in, quote, normal DGHs, normal district general hospitals. They don't work in the big shiny places. That's where the vast majority of patients are looked after. It's where the vast majority of clinicians are. So it doesn't really, I'm not going to name towns, it doesn't really matter which town you're in as to whether a clinician is going to be engaged or not. Some of our studies, we know roughly how many participants get recruited. The proportionate recruitment to studies and isn't based on where people are. It's based on the engagement in those local sites. And a lot of that is so, in a way, non-reproducible. If you have an engaged local lead, you have an engaged local lead, and you can't create an engaged local lead somewhere else just by saying next door's got one. Other people may have insights into that, and I guess as Aneel pointed out, that last 5%, if they're not engaged, it's not going to happen, and you have to accept that.
Mary, you've got a question for Aneel about authorship models.
Yes, and I see it's come up in the chat quite a bit, and going back to issues about what can go wrong, it can be a source of conflict. So I'd just be very interested in how you set up that model. And I know there's been some controversy in the academic literature. You had a response to your paper on authorship, which was quite skeptical, if I can put it that strongly. And I was just wondering what your response would be.
Don't slow down is my response.
Okay.
So yes, there are skeptics and they want us to slow down and change what we do. And I would be surprised if any of us on this call don't have our skeptics in our network. And one has to keep going and what you believe in. And you know, look, I don't mean to patronize the audience, but we're always patient first. If we believe it's good for the patient, we will do it. We believe that collecting this data is good for patients. And we're and so we stand by our authorship models, and we keep moving forward. We respond to these letters when they come. And yeah, you know, some people get left out of the authorship list by local leads, and that creates problems locally. But we solve it all for people. Everyone does this background admin that's boring and routine, but you have to do it to make our own projects work. So yeah, there are solutions there. There definitely are. Keep moving. Don't slow down for those things. Can I just, if I may, I'll respond to the last question as well of what are the challenges of amalgamating data across sites. And I'll keep it very short. Ethnicity is the key problem we have at the moment. And I don't have a solution. Around the world, there are so many different types of ethnicity. In Nigeria, there are 200 different ethnicities alone. So look, Black African doesn't cut it. And you know, the same is in England. You know, Black does not cut it. Asian does not cut it. And there's a huge interplay between migration status and socioeconomic status. So we're being pushed by the NIHR and others, the journals and everyone, to include ethnicity. But every time we've set out to capture it across our hugely diverse network, we have not been able to resolve it because we cannot create tight data sets. And there are some countries in the world where it's illegal to capture ethnicity data at a national level. So you end up in all sorts of problems because of previous historical context, genocides, for example. So one has to be, it's a really hard field. I don't have a solution. It probably doesn't, the NIHR wants to solve it. It probably needs a task force. I cannot lead that, but it's an interesting facet. I hope I'll stop there. I hope you don't mind me going off on one.
It's allowed. And actually, you've got a bit of a fan club in the chat. And you're being urged that the next project you think of should be about environmentally sustainable surgery, because that would prompt a lot of other work in the field. So there are a lot of questions for Aneel, but I'm going to just halt and go back to Ruth. What about the role of patient and stakeholder involvement in at-scale improvement study? We've already touched on this with Susanna, but how do you make it much more of a regular occurrence?
Absolutely. So thank you for that question. And for me, I'd split it down between the co-design work and the evaluation work. So with co-design, particularly when we're working across the system, it's important to think about people who need as well as people who use services. We need to access the voices of the people who are marginalised and excluded. And one of the techniques we use in our work increasingly is actually to work jointly with third sector organisations who are already accessing and working with individuals from the traditionally excluded communities, so that we're making sure that we're hearing their voices in the design of what we're doing. I think the other thing we would emphasise is the importance of ethical co-design work and making sure that it's trauma informed, so that everybody doing this improvement work with, particularly when we're working with multiple complex needs to be trauma informed in their practice. There's a real risk that we actually re-traumatise people in the co-design work. And the other big issue I think we would be calling out from our work is the moral duty to then act on what we hear. We have a major issue around co-design that we have asked communities multiple times about what their priorities are for improvement, what the things are we should be focusing on. And then if we don't act as systems on those issues, that in its own right can be considered traumatizing by those individuals. So there's something there as well about when we are co-designing, let's make sure that we then move forward and implement, because we're just building up bigger problems if we don't.
Terrific. Mary, I'm going to give the last word to you. You've got 20 seconds. Who pays? Local, national?
I think that is the question I can't answer. We need a coordinating infrastructure, and I'm not sure it's come into visibility yet. This institute plays a role. The big colleges play a role. Aneel has done fantastic things with his NIHR funding, but that's the infrastructure we kind of need to bring together. Thank you.
Terrific. Well, what a great session that was. Thank you all so much. You have a devoted fan club. The chat's gone absolutely wild. So Mary, Iain, Aneel, Susanna and Ruth, and a special mention for Aneel's moustache. Thank you all so much. So we are now going to another of the feature fellows. Hooray! These presentations are always so great. We're going to Georgia Black. She's going to talk about detective work, and in particular how clinicians investigate potential cancer patients who have non-specific symptoms. Georgia Black.